Hello dear friend, this is a very interesting case of a central perforation with ossicular discontinuity where we found that there was a heavy disease in the mastoid and all was hypertrophic mucosa. And for this patient, since mucosa was in very good health, so we decided to go ahead with intact canal mastodectomy. So before proceeding to the main surgery, so first of all, we are just raising an interlay flap because in this patient we are planning for a primary osteoplasty with TORP. So for that, it is utmost important to raise the interlay flap so that we want assurance that tympanic membrane graft uptake should be there. For that, interlay tympanoplasty gives very good results. So interlay tympanoplasty flap is almost 360 degree and it is left attached to the malleus, and once we mobilize the anterior and posterior flaps from the tympanic sulcus. So here we are mobilizing the tympanometer flap from anterior sulcus. So and then to expose it more, so now we are just exposing chorda and then seeing the status of the ossicle. So it was decided that this patient has to go for an intact canal wall mastodectomy since patient was young and we didn't want to give a cavity to the patient, and then mucosa was also middle ear mucosa was also in a good health. So we decided to remove this hypertrophic mucosa with the intact canal wall mastodectomy. So the primary step in intact canal wall mastodectomy is to make a very good cortical cavity first. So here we are doing a cortical mastodectomy. It is little bit different from standard cavity that all the landmarks has to be exposed. The lateral semicircular canal has to be exposed and dura has to be exposed and sigmoid sinus also has to be exposed. So here we are making exposure. So now it is utmost important to thin the canal wall adequately, and since we want to preserve the chorda, so care has to be taken not to the injure chorda posteriorly in the canal wall. So now we see that incus was eroded and it was removed. So now after removing the incus, so we are seeing the hypertrophic mucosa is engulfing the lateral semicircular canal, and also it is hampering the aeration of the attic region. So we are removing the hypertrophic mucosa. So once this diseased mucosa we are removed, so now we almost done with the atticotomy. So once attic is exposed and we know that there is no unhealthy mucosa in the attic, so next focus is to expose the stapes area. So here once attic is exposed, so now we are going to expose the middle ear through this route. So as we do posterior tympanotomy regularly in cochlear implants, so this technique is of intact canal wall mastodectomy is very important in preserving the canal wall, but it has a limited indication. I mean, it has an indication where your mucosa is maximum mucosa has to be preserved. So if you remove majority of the mucosa, then this technique fails. So our aim is to preserve the maximum healthy aerating mucosa. So now since the stapes is also eroded, so now we are exposing the facial nerve. Now you see we are exposing the facial nerve through this route. So finally we are exposing mastoid and tympanic segment of the facial nerve. And once we expose the facial nerve, we take all the diseased mucosa of the facial recess. So now coming to the foot plate area, so it was expected that foot plate stapes was partially would have partly eroded. So now this stapes is badly engulfed in the diseased mucosa and it was partly eroded. So the important is to expose the foot plate area. Once we expose the foot plate area and we see it is immobile, so now before proceeding to the ossiculoplasty, so we are just making sure that we are grafting the with tympanic membrane with the temporal fascia. So here, so we are grafted the central perforation, and now we are placing the top. So it is a top with the Teflon with the fluoroplastic head. So our aim is to follow the principles of osteoplasty. The most important principle of osteoplasty is that the angle should be very erect and then the stability should be good, and it should lie away from the outer attic wall. So this is the position. So now since malleus we are going to remove, so we have to make sure that angle is very erect in this patient. And if we maintain a 90-degree angle, and these are the implants which are going to work. So, and we confirm the position on stapes footplate, and because even though cartilage interposition is not required for this particular kind of implants of this company, but still we are placing the cartilage for a safety and for a 2-point fixation. And then we use a lot of a bone patty, so minimum attic defect which was made is obliterated with bone patty. It is excellent material for minimal obliterations of particularly bony obliterations. And once we just repair the attic, and then gel foam is placed, and confirmation was also done from the posterior root. Thank you so much.